good morning. My name is Mike Nielsen, and I am the orthotist over at Bender's Shoes in Grand Rapids and Hibbing and Duluth. I come from primarily, I'm in my clinical background, I come from primarily lower extremity and neuro. So I've spent my whole career in gymnasiums with physical therapists, caring for patients with strokes, head injuries, CP, MS, so on and so forth. As a result, I have had to learn some things about shoes. As some of you physical therapists know, shoes can be our nemesis. We can put a $3,000-4,000 brace in a $20 shoe, and we've lost everything we're trying to control. And so, having made lots and lots of foot orthotics, UCBLs, SMAFOs, AFOs, CAFOs, I had to become familiar with shoes. And so some of those shoes, as you may know, we need to have shoes that have extra depth to them, a broad toe box, something that we can secure a heel. These are some of the characteristics. And so let's just say you have a patient that you've diagnosed with a flatter foot, a pes plenos valgus foot. Well, then I'm going to look at probably a shoe that has a straight last rather than a athletic last. How many times have you had a patient come in and you can actually look at them walk and you can see their medial arch is falling off the side of the medial side of the shoe? Well, an athletic last, you can see how the sole, actually it starts out here, it sweeps in underneath the medial arch, right out from under the medial arch, and then back out again. And as a result, there's nothing under a person's arch. So we're going to look at something that has a straight last. So you can see that the sole is underneath the arch support, is underneath the foot. If we have a little bit more substantial medial collapse, then we'll look at a foot orthotic. So now we have a sole that's underneath the foot orthotic that is under the arch. Now let's say we have someone who has posterior tibialis tendon dysfunction. Okay. Well, now we know we want to keep that arch elevated. We want to keep that navicular insertion point elevated. So I will fill the medial arch. I'll fill it with some padding and put that into a shoe with a straight last, so we can keep that insertion point as elevated as possible, giving the patient as much function as we can and decreasing their pain as much as we can. So there is some of our treatment plans for people with flatter feet or posterior tibialis tendon dysfunction. Let's say we have someone with a cavus foot, so they're walking on the outside of their foot. Well, as you know, a cavus foot walks more on the lateral border of the foot. So that's your patients who you see come in and the foot is leaning off, while they're staying at the foot is leaning off to the lateral side, and you're going to hear them talk about everter pain, probably the lateral lower leg, pain just distal to the lateral malleus or at the base of the fifth where the insertion points are. So I'm going to put them in a shoe that is a little bit more firm, because a high arch can overpower a soft shoe, a soft-soled shoe. And then I'm also going to probably do some lateral wedging so I can get that foot plantar grade. So I will put some wedging under the heel and the forefoot to get the foot plantar grade in the shoe. As for those, earlier I was talking about the folks with a moderate to severe medial collapse, or your patients with the posterior tibialis tendon dysfunction. I'll do medial heel and forefoot wedging for them because I like to use the forefoot and the hindfoot to help me lift the medial arch, because I don't want all that pressure on the medial arch alone. That can be very uncomfortable. So plantar fasciitis is something that you guys see a lot of. And we see a lot of that here as well. So let's just say you have a patient that you're sending in because of plantar fasciitis, and you'd like to have something that will help them. So then we're going to look at a shoe that will, again, accommodate a nice insole. We'll have these people come in who are looking for a plantar fasciitis shoe, and there really isn't such a thing. There really isn't. They need arch. They need something underneath their arch to keep their plantar fascia stretched, elevated, so that it can't flatten out and get that tear. There are a number of shoes that will do that. I still like to have a shoe that's got some structure to it, something with a straight last, preferably. And then we're going to we're going to introduce them to an arch support. This particular arch support is from a company called Cadence. It is a company that was developed by some physical therapists out of San Diego. Having made quite a few foot orthotics, this is one of the nicest ones I've ever seen. Very anatomical, very well structured. The top cover is silicone rubber. They fenestrated the heel, so someone with a heel spur gets a lot of offloading benefit from this. Very nice insole. And so I will show those patients. First, I want to isolate, okay, is it really plantar fasciitis? I want to make sure we don't have a heel spur or maybe Achilles tendonitis. I want to make sure of that. And if indeed it is plantar fasciitis, then I'm going to introduce them to a foot orthotic. I'll look at their arch while they're non-weight bearing to get an understanding of just how high their arch is. And then I'll insert it into a shoe and let them walk around and see if we have brought them any comfort. The other thing I'm going to do, and I've just learned this from physical therapists and docs over the years, is that typically a doctor or a PT is going to send them to me and they've already told them no going barefoot. Sometimes you have patients who don't want to hear that, but we want to get them through this stage of their life. So no going barefoot. And then when they get out of bed in the morning, they want to swing out of bed and step into something with arch supports. They can use the shoes with the insoles that they're already walking in, or I'll mention to them, this is something that we have a lot of doctors and PTs send people in for. It's a Haflinger, and basically it is a Birkenstock with a wool cover, and very popular. People really like this. Or I'll mention a Birkenstock because it's something you can wear not only in the house in the wintertime, but you can wear it in the springtime. Very anatomical footbed, great medial arch, lateral arch, and has a transverse arch that goes right in, that slips right in behind the metatarsal heads. And so that is kind of the treatment that I provide for people with the plantar fasciitis. Something that they wear in the house so they're not going barefoot, and then an arch support that they can put into their shoes and keep that arch elevated. That's been very successful. Another thing that you will be familiar with for some of your patients is Morton's neuroma, whether that is coming from a decreased transverse arch or a shoe that's too tight in the forefoot, or a combination of the both. We can work with that. So if you have a patient that you have diagnosed with a Morton's neuroma, then what we're going to do is we're going to look at a foot orthotic that has a metatarsal pad in it. We want to restore that transverse arch. So once again, I really like the Cadence. It has a transverse arch that, I don't know if you can see this in the camera, but it has a very nice transverse arch, about 3/16 to 1/4 inch high. We'll put that into a shoe that will support the orthotic itself, and we'll make sure that they have a shoe that is going to give them room, say something like this. So we've got a toe box that's going to let those metatarsal heads relax, let them spread apart, and then get the transverse arch of the orthotic into the transverse arch of their foot, separate those heads and get the impingement off that nerve. You may have a patient with Achilles tendonitis. So we want to elevate the heel so we can take the tension off of that Achilles tendonitis, off the Achilles. So the first thing I'm going to look at is I want a shoe that's going to fit the contour of their foot. I want their foot to be comfortable in the shoe. I'm going to look for a shoe that has a heel to forefoot drop, because I'm not going to let them be in a van. I have 3 daughters who love vans, and those vans just drive me up a tree. I do not like vans if we have a decreased range of motion. So I'm going to look for a shoe that has a heel to forefoot drop. Most tennis shoes have a drop of 1/2 inch to 5/8 of an inch. And then we also have heel lifts. And so I'll put a heel lift under the insole of the shoe. So now we've got a 3/4 inch, maybe a 1 inch heel to 4-foot drop. And then as the Achilles tendonitis improves, these adjust-a-lifts are layered. So you can pull 1/8 of an inch off maybe every week, every 2 weeks, until you no longer need a heel lift. And that has been very successful, almost instant relief, of course, when you take the tension off that tight Achilles. Patients with diabetes who need maybe a diabetic insole or a diabetic shoe, the A5500 class shoes, we do carry those at vendors. New Balance makes quite a few of them. There is the 928. There is the 940, the 1540. There are a lot of, New Balance has a lot of shoes that qualify as a 5500 shoe. When we have patients with diabetes who also have neuropathy, I really like to put them into a firmer shoe. And particularly, if you have a patient, if the neuropathy is at the place where their sensation is very decreased, I want to get the best signal from the stretch receptors in their feet as I possibly can. And a soft shoe, what I've noticed with patients who have fairly significant neuropathy and their balance and stability is impaired quite significantly, the soft shoe is not a good shoe for them. The reason is the shoe allows an additional amount of excess motion in the foot. And by the time that their stretch receptors are getting a signal to their brain that, hey, something's going on, correct, they're already falling, and they're going to try to catch themselves, of course, and now we're going to deal with their rotator cuff issue. And that's the last thing we want. So I will go for a stiffer last shoe. I don't want a shoe that can do this, because I don't want their foot to do that. I want a shoe that won't do that. And then with the diabetic insole, so I make sure that we have a stiff shoe to activate the stretch receptors as quickly as possible, and a soft cushion insole to give them that cushion from that diabetic skin. Arthritis, kind of the same thing. So if you have a patient that you've diagnosed with arthritis and you want a particular shoe for them, I like a stiff shoe, because in my experience anyway, arthritis kind of likes to be held snug as a bug in a rug. It doesn't like excess motion. There's normal motion in the ankle foot complex, but there's excess motion that exacerbates the arthritis. And so once again, I don't really care for a soft shoe, because we don't want this much motion in the joints of the ankle foot complex. We want a stiffer shoe that will decrease that excess motion and decrease their pain, increase their comfort and stability as well. So a stiffer shoe is what I'll go with. If alignment is an issue, I am kind of a fanatic when it comes to alignment. I over the course of my career, I think I've learned that alignment equals stability, and an increase in function, a decrease in pain if we're dealing with pain. And so I look at the alignment of the ankle foot complex, the knees, the hips. A typical evaluation for me is, while they're telling me what they're experiencing, I'm going to pull their shoes and socks. I want to watch them walk. I'm going to do a little gait analysis, and then I have them sit back down, and I want to get a feel of their hind foot, their midfoot, and their forefoot, because I want to know how that foot functions. And during this time, I'm thinking through, okay, what do I need in terms of a shoe or an orthotic, if that's necessary, to give them the greatest alignment and comfort that I possibly can. And so, and I do this with every single person that comes in the door who wants to see me. When a doctor or a PT sends someone to me, I really want to understand the biomechanics of that foot. Leg length discrepancies. So, we all we'll have people who come in who have one leg shorter than the other, and maybe we've got an iliosacral impingement because of that. So we've got some significant lower back pain. So the same heel lifts that we use, maybe for Achilles tendonitis, we'll try to equalize our leg lengths as quickly or as best we can to give them as much comfort as we possibly can. Some of the questions that I get from physical therapists: do you make custom foot orthotics? We do not. We are a shoe store. We're a retail store. So we do not do custom work here. Another question that they ask is, do our patients need to make appointments? They don't need to make appointments. We are putting together a link on our website that will allow people to go to Foot Health, and then they can go to either Grand Rapids, Hibbing, or Duluth, find an appointment with me. They can click a link. It will show them my calendar, show them the times that I'm available, and they can sign up for an appointment, or they can just walk in. It's perfectly fine. So I want to thank you for this time this morning very much, and I look forward to serving you. I just want to be an extension of your patient care. Thank you very much.